It's a pleasure to be here in such a charming and fascinating town as Istanbul, and I thank Dimitri and the organizing committee for the very kind invitation. Although the best approach to a child after a first febrile urinary tract infection is still a matter of controversy, I very much support this child who is trying to escape our concerns as doctors only because he has had a first febrile urinary tract infection with an uneventful recovery. And to be sure that you try to be convinced, I say no. And that's a big no because I knew I would have been in disadvantage from the beginning. Why urinary tract infections, febrile urinary tract infections, are so worrying to us as pediatricians and as pediatric nephrologists? Because we are worried of the long-term consequences these children could have. And this is the first report which appeared in the New England Journal of Medicine in '63, where 72 patients were studied, and they were hospitalized as children with UTI, and they were followed up to 27 years later. 18% of these children had died, and 30% had chronic kidney disease. Jean Smerley in London was the first to establish a relationship between pyelonephritis, late renal scarring, and vesico-urethral reflux, and Bailey called this relationship reflux nephropathy, a term that which we do not like a lot because it implies a causal relationship between reflux and nephropathy. But already during those years, in the 70s, there were some reports, and this is a French report, where 12 nephrectomies were studied. And those were nephrectomies performed because of a renal atrophy. And only in one case, the kidney was found to have lesions of chronic pyelonephritis. In the other 11 cases, there was a small congenital kidney, what we call now an hypodysplastic kidney. And that's why this is the concept which has been the fundamental for urinary tract infections for many years. Children with febrile urinary tract infections can have scars. Scars can lead to hypertension and kidney failure later in life. And that's why all children with a febrile urinary tract infection are investigated mainly to see if they have a reflux, and those with the reflux have been treated with surgery and antibiotic prophylaxis for many years. But is it true that UTIs in normal kidneys can really give hypertension and chronic kidney damage later in life? We have done a systematic review of the literature, and we try to see all children from 0 to 16 years with the first UTI or recurrent infections. And we have seen all the papers that had at least a follow-up of 2 years. And the outcome were renal function and blood pressure. From this research, we ended up with 29 papers and 22 cohorts of children. And as far as renal function, there were 15 cohorts of more than 1,600 children who were followed up for up to 27 years. But I must underline that 90% of these children had vesico-urethral reflux, and more than 40% had major scarring of the kidneys. Chronic renal failure or end-stage renal failure was present in a percentage which varied from 0 to 56%. As far as blood pressure, we have the same data for 1,500 children with a follow-up up to 27 years. And hypertension was present from 0 to 35%. So what we concluded from this review is that there is a very high heterogeneity of the population study, of the diagnostic criteria, of the evaluation of the outcomes. and that those were cohorts of children selected on the basis of the severity of the disease. Those were follow-up of high-grade reflux or dysplastic kidneys. And those are a very different population from what we see today after children with the first febrile urinary tract infection. And that is very difficult to establish a relationship between UTI and general morbidities. And there are recent data. This is the ITAL-KID, which is the Italian Registry of Chronic Renal Failure in Children. And this is a cohort of 187 children with reflux and chronic renal failure. And this is the diagnosis, the age at which the diagnosis of both chronic renal failure and VUR was made. 40% of male had the diagnosis performed at birth, and most of the children before the first year of life, with no urinary tract infection before. So we have two different situations: hypodysplasia, which is an abnormal kidney formation during gestation, and UTI-related kidney scar, which is a damage in a normally developed kidney. And if we go to population-based study, like this Swedish study, which followed up children up to 26 years after the first urinary tract infection, we have very interesting data. They took a group of children with scarring and a group of children without scarring. And of those children, they had the same glomerular filtration rate. Both the children with scarring and the children with no scarring. So we are now facing a situation like this. We have a huge number of children who have a febrile urinary tract infection. Of those children, 15% will have a post-infectious scarring, and 20% will have a reflux. But reflux is also present in children with no febrile urinary tract infections. And we have a small percentage of children with a hypodysplastic kidney, and most of them with high-grade reflux. And those are the children we have to worry because those are the children who will go into chronic renal failure. And if we go to see data from this is a randomized controlled trial which was done because of to evaluate the antibiotic of the first febrile urinary tract infection. But those children were studied with either ultrasound, an acute DMSA scan, a micturating cystography, and a DMSA scanning at 12 months to evaluate the presence of scar. Reflux was present in the 22% of children, but most of these reflux were grade 1 or 2. They were grade 1 or 2 in 40, grade 3 in 22, grade 4 in 3, and grade 5 in 1, only in 1. And scarring was present in 15% of children, 45, and most of those scarrings were small scarring of no clinical significance. And what is also interesting to see is that of the 45 scarring, 22 were present in children with no reflux and 23 in children with a reflux. Before to define the diagnostic protocol, I would like to say something on prophylaxis. And as far as prophylaxis, I would like to underline the different behaviors between bacteria and human that we have to consider when we utilize antibiotic prophylaxis. Bacteria are extremely numerous. They memorize generational experiences within a few hours. They have the capacity to transfer vast quantities of information in seconds. They have an extraordinary ability to adapt under the selective pressure of antibiotics, and they have an outstanding collaboration among them. Humans, they are often few and isolated. They have endless discussions, at least our politicians in Italy. They have difficulty in confronting and in resolving issues. They have a tendency to maintain the same diagnostic and therapeutic approaches for ages. And they have a scarce collaboration for the most part. So we lose against the bacteria. Bacteria win. And the other point we have to underline when we speak of antibiotic prophylaxis is that reflux is a very heterogeneous entity. We have 5 grades of reflux. Grade 1 is very different from grade 4 and grade 5. It's very, very different. We have a very tiny reflux in a non-dilated ureter which doesn't go to the kidney. And grade 4 and grade 5, we have a dilated ureter with a very much more difficult situation. And we can see those data also from the very recent randomized trials which have been published, the 6 randomized trials. Those are children who were on the no prophylaxis arm between 2 and 24 months of age. And those are the number of recurrences on the basis of the grade of reflux. And we see that if you do not have a reflux, you have a 6% possibility to have a recurrence in the 2 years following the first febrile urinary tract infection. You have the same possibility if you have grade 1 reflux. You have 8% possibility if you have grade 2. But things start to be different when you have grade 3 and grade 4 reflux, which is a much higher percentage. And if we go to see those trials, which have been recently published, this is a meta-analysis, we see that taking all together the data, there was no difference on the recurrence of symptomatic UTIs between the children who were on antibiotic prophylaxis and those who were not on antibiotic prophylaxis. And the same happens for the new or deterioration of renal scars. There's no difference. But if we go to see the trials in particular, we have no difference for the primary outcome as far as all the population of the study. But if we try to differentiate the grade of reflux, it starts to appear a certain difference. 43% of children on no prophylaxis with grade 3 reflux had a recurrence, and 23% of the children on prophylaxis had a recurrence. There was no difference, but the trial was not designed to see this difference. It happens the same with the French study. Boys with grade 3 reflux had a significant difference. And this is the Swedish trial, which is quite interesting. They randomized 203 children to 3 arms, 69 to prophylaxis, 66 to endoscopic treatment, and 68 to surveillance. And what they found is that girls on the surveillance treatment, on the surveillance arm, had a much higher, significant increase of recurrence of febrile UTIs than those on prophylaxis or those treated with the endoscopic treatment. So we stick with what are our recommendations, which have just came out in Acta Pediatrica a few days ago, that we need to consider prophylaxis only for reflux grade 3 to 5. And as far as the diagnostic protocol, there are many guidelines published with very different scheme. The most recent one are the American Academy of Pediatrics. They suggest to perform to all children following a febrile UTI a renal and bladder ultrasonography. But they suggest to select the children to whom perform a VCUG, a cystography, on the basis of the results of the ultrasound. And our Italian guidelines are quite similar to those. We'll perform cystography and renal DMSA scan only on those children with a positive ultrasound or some risk factors such as an abnormal prenatal ultrasound, chronic kidney disease, the presence of chronic kidney disease, the presence of abnormal bladder emptying, or some other points. So, in conclusion, from the old concept, we are now to this new concept, which I believe is the current understanding of febrile urinary tract infections and renal scarring, that most of the hypertension and kidney failure is secondary to dysplasia, which is related to genetic problems, defects. There is a role of UTI-related kidney scarring, but is a small role, which is quite important for those children who have hypodysplasia and high-grade reflux. And that nowadays we need to look only for those children with higher grade reflux, and those are the children who need to be treated with antibiotic prophylaxis. Thank you very much. Thank you, Ether. I agree with you that we are saying most of the same things, but we're interpreting the things from two different points. And as far as reflux, I just want to say that reflux is very common. The incidence of reflux is 1%, which means 10,000 per year per 1 million of pediatric population. But the incidence of reflux and CKD is 3-4 children per year per 1 million of pediatric population, which is very, very different. So that's, reflux is very common, UTI is very common. Fortunately, chronic kidney disease is very uncommon. And the other point that I would like to make are side effects that we can have from the use of imaging, a wide use of imaging, and a wide use of antibiotic prophylaxis. Cystourethropy and renal DMSA scan have a radiation burden, have an associated pain and distress for the patient and the family, and have a cost for the social system, the national health system. And as far as those investigations, I want to make a point on these 300 children from 2 to 24 months of age who had their first febrile urinary tract infection. Those children were investigated in a randomized control trial. 21% had reflux, grade 1 to 5, but only 8% had reflux, grade 3 to 5. And 15% had scars. What would have happened if those children would have been investigated with the Cincinnati guidelines, the NICE guidelines, the Italian Society of Pediatric Nephrology guidelines, and the New American Academy of Pediatric guidelines? This is the total cost in euros. This is the total radiation in millisievert, and those are the number of reflexes missed. Number of reflexes, grade 3 to 5, grade 1 to 5, and number of scar missed. Here, the Cincinnati, which recommends to perform to all children cystography, to all children a renal DMSA scan, is not going to lose any of those reflux or scars, but it has got a very high radiation burden for the population in general. As far as the American Academy of Pediatric recommendations, the total radiation is 42, because they do not recommend to perform renal DMSA scan to any patients, and they would have lost all the scars. As far as the NICE guidelines, they would have missed 13 of the grade 3 to 5 reflux, and most of the small reflexes. But you can pick up, and the Italian guidelines would have missed only 7, but with a higher radiation dose. But you could pick up those 7 or 13 high-grade reflux later when they have a second infection. And I just point out to the radiation burden with this very recent paper appeared in the British Medical Journal this year. This is a case control study where 2,600 children with a cancer were evaluated, and almost 5,000 children served as controls for matched for age, sex, and region. And what appeared from this data that early exposure to diagnostic X-rays in early infancy within the first 100 days of life was associated with a small, non-significant excess risk for all cancers, but was associated with a significant increased risk of lymphoma with an odds ratio of 5. And the other point is the side effects we have from the wide use of antibiotic prophylaxis. This is a very interesting study which appeared in The Lancet in 2005, which evaluated the use of antibiotic on an outpatient basis in Europe. It appears that antibiotic is used in a very different way among the different countries in Italy, with a very high use in the south part of Italy and very low use in the south part of Europe, and low use in the north part of Europe. And what appears from this study is what we really already know, that there is an increase of resistance of bacteria. This is France, which had the highest use of antibiotic, with the use of antibiotic. So we have to keep in mind this. And this is especially true for children who have the highest consumption of antibiotic versus adults. So I finish my rebuttal with the same word: no, it is not necessary to study our children. Thank you.